PMLE is progressive multifocal leukoencephalopathy. We would be studying the topic under introduction, virology, epidemiology, pathology, risk factors, clinical features, imaging, investigation, and treatment. It was the first reported virus-induced demyelinating disease in humans. It is caused by John Cunningham virus, also called JC virus, belong to human polyomavirus group. It's a neurotropic virus. There is primary ingestion or inhalation of the virus, following by there is quiescent stage where the virus lies in the kidney, bone marrow, or lymphoid tissue. The primary infection of JC virus is asymptomatic, after which the virus becomes clinically latent, and 86% of the general population are seropositive for JC virus. Following that, the patient, whenever are predisposed to the immunosuppression secondary to an infection or any drugs, that leads to viremia. There is multiplication of virus, and the virus bound to the B cells, and viruses are present as individual virons in the blood. Later, the B cell bound virus enters the blood brain barrier, infects the oligodendrocytes, causing demyelination. Before the HIV pandemic, PML was a rare disease only seen in few immunocompromised patients, including the individuals of hematological malignancies, organ transplant recipients, and patients of chronic inflammatory disorders. When the HIV pandemic happened, in which up to 5% of patients with AIDS developed the disease. And then later, newer group of patients with PMLE has emerged among the patients treated with immunomodulatory drugs. Treated with these medications, particularly natalizumab used for the treatment for multiple sclerosis and Crohn's disease were prone, and patients where lymphoma patients were treated with rituximab or efalizumab was used for psoriasis. These patients were prone for developing PMLE. Definitive diagnosis of PML requires demonstration of demyelination seen on MRI, bizarre astrocytes, and enlarged oligodendrocyte nuclei seen on brain biopsy, and other techniques shows the presence of JC virus. Luxol, blue staining used for the demonstration of the virus. PMLE associated demyelination affects both subcortical white matter and the cortex, and JC virus causes infection of these cortical neurons and demyelinating lesions. The underlying conditions which predisposes to PMLE are malignancy, HIV infection, particularly when CD4 count is less than 200, organ transplant patients, and bone marrow transplant patients, and patients who are receiving natalizumab and other drugs also, such as cyclophosphamide, leflunomide, and methotrexate. And associated with other autoimmune diseases include SLE, vasculitis, granulomatous polyangiitis, dermatomyositis, polymyositis, scleroderma, and rheumatoid arthritis. And it is also associated with primary immunodeficiency disorders. There are various clinical forms of PMLE, includes classical PMLE, inflammatory PMLE, and other various clinical forms. The classical PMLE usually manifests with subacute neurological deficits including altered mental status, motor deficit, limb ataxia and gait ataxia, and visual symptoms such as hemianopia and diplopia. PML typically spares optic nerve and spinal cord. Although the lesions are mainly located in the white matter, PML symptoms are frequently indicative of cortical disorders. Seizures is usually though a manifestation of cortical injury rather than white matter disease. Next is inflammatory PMLE, also called as PML immune reconstitution inflammatory syndrome, which is associated with new onset or clinical worsening of PMLE with contrast enhancement of PML lesions. PML iris occurs mainly in the patient with HIV undergoing ART treatment, where there is marked increase in CD4 T cell counts and decrease in viral plasma load. And patients with multiple sclerosis who are treated with natalizumab may develop PMLE, followed by there will be development of PML iris after withdrawal of natalizumab and restoration of the immune system. Other conditions caused by JC virus infection includes JCV granular cell neuronopathy, JCV encephalopathy, JCV meningitis, JCV cerebellar granular cell neuronopathy has to be differentiated by from the PML cerebellar syndrome, where the lesions occur in the cerebellar white matter. The preferred imaging modality is MRI, showing white matter hyperintensities of subcortical U fibers, splenium, corpus callosum in the posterior cerebral hemisphere. PML lesions usually begin in the subcortical white matter and particularly in the parieto-occipital or frontal lobes. May also involve corpus callosum, brainstem also. There is involvement of deep brain structures such as basal ganglia and thalamus, and the lesions do not contrast enhance. Enhanced PML lesions may occur with PML iris. On CT scan, we see hypodense white matter lesions. In MRI, we see T2 hyperintense lesions. There is no specific vascular territory involvement. There is devoid of edema, mass effect, and contrast enhancement of these lesions. But the gold standard for the diagnosis of PMLE is brain biopsy, where we can detect the viral DNA and proteins by IHC or in situ hybridization technique. It has sensitivity of 65 to 95% and specificity almost 100%. The CSF also aid in diagnosis by detection of JCV DNA by PCR. Due to lack of specific treatment for PMLE, there is no directly acting anti-JC virus treatment. Here we control only the risk factors and judicious use of the immunomodulatory drugs. For a patient who is infected with HIV and PMLE, we use highly active antiretroviral therapy. There are few other drugs which have shown benefit in JCV virus treatment, includes JC virus cell entry inhibitors, includes the drugs chlorpromazine, citalopram and mirtazapine, which blocks the serotonin receptors and inhibits the JCV virus infection and replication in glial tissues. Summarizing with the pathogenesis of the JC virus, primarily there will be infection by nasal or oral route, followed by there will be stage of quiescent stage where the virus will lodge in bone marrow and kidney. Whenever there is a predisposing condition by immunosuppression, there is virus reactivation, entry into blood, viremia and CNS invasion. Thus completes PMLE.